from Medicine 3. I'm presenting this patient. This is about Mr. R approached us in OPD with his wife, Mrs. D, who is a 45-year-old lady with in her postmenopausal period with no known comorbidities, a housewife from Tirupattur with chief complaints that she was noted to be unresponsive in the early hours of the day, lying drowsy in the bed, not answering back, and looks weak. And after the breakfast, she gradually improves and was normal throughout the day. There was recurrent such episodes in the past 4 years. However, the episode was not associated with abnormal movements, bowel bladder incontinence, or post-episodic confusions. She was extensively evaluated as seizure disorder elsewhere. The imagings and the EEG done were normal, so the possibility of psychotic disorder was considered. So we reviewed her outside reports. We noted that 2 of the outside reports during the episodes have documented hypoglycemia. So on examining her, she was conscious and oriented, and she was afebrile. She was obese according to her BMI, and there was no pallor, icterus, cyanosis, clubbing, or no lymphadenopathy or pedal edema. She had acanthosis nigrans and multiple skin tags around chest. Her thyroid was normal. Her vitals were like, her pulse was 88 per minute with regular in rhythm with a blood pressure of 120/80. Examination of her CVS revealed normally heard first and second heart sound, with examination of the ORS revealing normal vesicular breath sounds. Her abdomen was soft, non-tender, and no organomegaly could be made out. And her CNS examination was also normal. So at the end of this, we had the syndrome complex of recurrent episodes of unresponsiveness, especially in the early mornings, and gradually recovering after feeds. So breaking out the syndrome complex, the confusion and minimal responsiveness is suggesting hypoglycemia, and there was documented low blood glucose level, and the symptoms gradually improved with the food intake, which forms the basis of the Whipple's triad. So based on this Whipple's triad, we approached her in view of insulinoma. So the approach is mainly based on the concept failure of endogenous insulin secretion to be suppressed by hypoglycemia is the hallmark of the insulinoma. Thus, the finding of inappropriately elevated levels of insulin in the face of hypoglycemia is the key to diagnosis. And we approached her in this stepwise manner. First, we demonstrated the fasting hypoglycemia, for which she underwent 72-hour fasting test, in which the procedure is conducted like when the patient commences fast, she is allowed only to have water, and blood glucose is monitored at regular intervals of 4 to 6 hours, and whenever the patient develops symptoms of hypoglycemia. So Mrs. D had glucose level of 41 mg per deciliter at the 5th hour of the test, thereby demonstrating the fasting hypoglycemia. Second, to establish hyperinsulinemia in this condition. So this is done by when the blood glucose level reaches 40 mg per deciliter and the patient develops symptoms of hypoglycemia, blood samples for insulin were collected. Normal response at this level will be insulin of 3 to 6 milliunits per liter, whereas more than 6 milliunits per liter predicts insulinoma, and Mrs. D had insulin of 10.8 milliunits at this period. Third thing is to demonstrate endogenous hyperinsulinemia. C-peptide is also looked at the end of the fasting. Normal C-peptide is 0.2 nanogram per ml, whereas Mrs. D had a corresponding C-peptide value of 8.96 nanogram per ml, which was elevated. Next thing is to identify and differentiate the cause of hyperinsulinemia, whether it is due to the insulinoma or insulin antibody syndrome. This is identified by calculating the molar ratio of insulin to C-peptide. This is based on the concept, while pancreas secretes insulin and C-peptide in equimolar amounts, insulin binds to antibodies in patients with insulin antibody syndrome. However, the C-peptide continues to be metabolized at its normal rate with a half-life of 20 to 25 minutes. Thus, in a fasting state, C-peptide levels are low in insulin antibody syndrome, making the normal molar ratio more than 1 in insulin antibody syndrome and less than 1 in insulinoma. And Mrs. D had molar ratio of 0.26. Thus, she was biochemical. She was confirmed with biochemical evidence of insulinoma. The next step is to localize the lesion. This is done by CT. We carried out with CT abdomen, in which a lesion is identified in the uncinate process with a likely clinical setting more towards favoring insulinoma. Further study with MRCP also confirmed the same, a lesion in the uncinate process of the pancreas. So looking into the insulinoma, it is a pancreatic neuroendocrine tumor with an incidence of 4 per 1 million. However, this is the most common functioning pancreatic neuroendocrine tumor. The most common cause of hyperinsulinemic hypoglycemia in an adult. It will occur usually in solitary. If multiple insulinomas are identified, higher chances of being a part of main one should be considered. The insulinoma could be benign or malignant. Management includes medical management and surgical management. For benign lesions, dioxazide that acts on the sulfonylurea receptor of the beta cells is used, or octreotide analogs can be used. In malignant lesions, the current therapy given in malignant conditions are combination therapy with 5-fluorouracil with either streptozotocin or doxorubicin. And newer agents, dacarbazine and temozolomide based regimens are being studied. Surgical options are achieved, reserved in patients who do not respond to medical therapy. Surgical resection achieves cure in 90% of the patients. Enucleation is the preferred technique. So Mrs. D was given tablet dioxazide 100 mg, and she was noted to respond to medical therapy, and she is on continuous follow-up. So the recent advances in insulinoma were the major problem in detecting insulinoma is delocalizing the tumor. For this, the functional imaging targeting GLP-1 receptor is being carried out as insulinoma express it in high level. GLP-1 analog labeled with indinium 111 was being done. That is a very accurate procedure. And a new protein to predict insulinoma behavior, alpha internexin, is being studied. So high clinical suspicion with a history of patient is highly recommended to pick up neuroglycopenic symptoms of hypoglycemia mimicking CNS disorders, as the entire workup starts with identifying the Whipple's triad earlier. These are my references. Thank you.
Thank you. So that's a pretty rare syndrome. Any questions? So that was a nice workup that you described. Praveen, good if you could have made it like an algorithm, the various steps where you approached the hypoglycemia. Okay. Next, we have